with being the last presenter is that you have to try and anticipate what everyone else is going to talk about, so you don't just say the same stuff, because that would be super boring. So what I thought I would do is try and put something together that spoke to what I was hoping everyone would allude to during their presentations, and that is the fact that, as Chris Orton has mentioned, that there is a learning curve, and we need to understand that. If anyone in this room is considering starting a program either for edge-to-edge repair or for open mitral valve repair, you've got to know what you're letting yourself in for. And arguably, these things are or will require an expert performance from not only the surgeon, but all of the different components of the team that you've heard discussed. So I thought I would perhaps delve a little bit less into hard science and more into a little bit of social science, and talk about learning curves, maintenance, volume, and expert team performance in what is arguably probably one of the most challenging, complex socio-technical environments that we as veterinarians might ever find ourselves in. So I set about this, and I thought, well, this is, people might be wanting to set up programs, and it's actually very hard to work out how many active mitral valve repair programs there are in Japan currently. Estimates are between 4 and 7, and of course the famous ones we've heard about here. There is the program that we've also heard about in Florida. In the UK, we've got one active centre. There's a promise of another centre to become active in the next few years. And we've got colleagues in Korea and in Versailles in France also performing this procedure. So it did make me wonder whether there was a better alternative title for this presentation. And that would be, you don't have to be Japanese to do mitral valve repair surgery, but it helps. So that's really interesting, isn't it? Why does it help? It clearly helps. And so maybe we can probe that in a non-confrontational and in a politically correct way. And if it's not politically correct, then I apologize to anyone from non-Japanese countries. Why am I qualified to talk about this? I'm not sure I am, really, but this is a little montage of images from the time I was at the University of Pennsylvania between 1995 and 2000. As Professor Orton knows very well, we were dabbling with open heart surgery, and I performed, along with some very eminent human heart surgeons, mitral valve repair attempts. And okay, so the obvious thing to notice is these are all post-mortem pictures. But this is an Alfieri stitch with pledgets, with a commissuroplasty. This is an annuloplasty ring, and this is a valve replacement. This is Professor Michael Acker, who is head of cardiothoracic, still is head of cardiothoracic surgery at the hospital at the University of Pennsylvania. And this is Lynn Boggs, who is a practitioner in Texas that reported a single case report of a repair in a dog. And that surgeon there is Sam Weinstein, who was an eminent pediatric cardiac surgeon at Children's Hospital. So I thought I was surrounding myself with people that knew what they were doing, and again, the experience of human valve repair surgeons trying to do valve repair in dogs was that they thought it was just too difficult, very, very challenging. So at Penn, we concluded, size mattered. I know Professor Orton felt very strongly at the time that dogs over 5 kilos were okay, but anything less than that was going to be problematic, and most of these dogs are less than 5 kilos. Standardizing personnel and protocols was going to be essential. A coordinated team effort was required. Patient selection was critical. And at the time we dabbled with that mitral valve surgery, we had other conditions we treated surgically, pulmonic stenosis, double chamber right ventricle, intracardiac tumours, and we had some success. So I was keen, if I ever delved into this again, that I would focus on bigger dogs and try and steer clear of dogs with mitral valve disease with a poor left ventricular function. So that's what we concluded, and one of the great things about this presentation and this opportunity is that it gives me a chance to say a huge thank you to folks who have been very helpful to me along the way. So I moved from Penn to the Royal Veterinary College in 2000. It took a while for us to get up to speed in terms of our facilities and personnel and so on, but in 2005 we were very lucky to have a very wealthy client who wanted to pay for a team from Colorado to come over and fix her dog's tricuspid valve, and very graciously Chris and his team came over. We implanted, or he implanted with me watching with my mouth open. You probably didn't realise it because of my face mask, but this was a tissue valve, the Perimount plus pericardial, bovine pericardial valve. We assembled a team at that time to work in parallel with the team from Colorado, and that dog did extremely well until it developed pelvic limb osteosarcoma 8 months later. And here's the owner of the dog. She paid for all our initial equipment. She didn't like to drive around the motorway to get from her house to London Vet School, so she used to come by helicopter, and the dog used to have to wear defenders. So that got us started again, and I'm renewed by this success. Turned out to be a slightly false dawn, but we kept progressing, and we operated on quite a few dogs with pulmonic stenosis, quite a few dogs with tricuspid valve dysplasia. And so by the time 2012 came along, I met Masami and actually met him here in Seattle in 2010, and we had a little discussion, and he brought his team over to operate on this dog with mitral valve disease, and that really opened our eyes to the possibility again that we may actually be able to achieve mitral valve repair surgery in our hospital. And Heidi there lived many years after successful repair. So since that time, this is what we've been up to. We've accumulated 260 mitral valve repairs. Maybe something for discussion later, look at the proportion of B2, C and D dogs, and I think that might be an interesting discussion point later. We've also operated on quite a few other interesting things. We've had quite a few dogs with AVSD and so on. So we've had an active program, and we've been slowly increasing our throughput. And I published, or we published the outcome of our first 132 mitral valve cases quite recently in Vet Search. And we showed that we divided those patients into 4 equal sized cohorts, starting from 2015 all the way through to 2022. 33 dogs in each group, and you can see that we got gradually better over time. So you might say this is the sort of publication that belongs in the journal of stating the bleeding obvious, that the more you do, the better you get, and that's true. But I'm intrigued a little bit more by not only what happens in the operating room, of course, but this is the team effort, it's a team performance, and how many do you need to do to get good, and how many do you need to do to stay good, and that's probably the essence. So it's not just what happens in the operating room. That's important, but it's not just what happens. So looked into what we thought needed to be in place for us to have success in open heart surgery. So it's a multidisciplinary team, and that team, as Chris has described with TER, you have to make team decisions. Everyone's got to have skin in the game, basically, and you've got to make team decisions. You need to define together what you believe for your group, for your program, constitutes a good surgical candidate. There are members of the group that will have to develop competence in technical aspects of different components of the treatment: perfusion, circuitry, vascular access. You need to develop the competence at pre-operative and intraoperative assessment of cardiac pathology and how to correct it. And then, of course, you need anesthesiologists that will develop the competence anesthetizing these dogs with disease, and competence at post-operative assessment and management. Goes without saying, that's what's required. So how do we go about getting, which I've been very fortunate all my practicing career. I've worked in very busy multidisciplinary hospitals with excellent people, and groups of excellent people don't always make a team of excellent people. So Bisbee and others, I looked into some of the literature and the social science of this, and this article sort of encapsulated what we needed to try and achieve, or what we had been trying to achieve, perhaps without realizing it. So you need to have a group of people that have a shared vision, shared mental models. They need to be adaptable, and Christ knows you need to be resilient in this business. But there also needs to be clarity of role and responsibility and dynamic leadership for this to work properly. Great cooperation, great coordination. Everyone needs to be positive, but you need to develop a psychologically safe environment, a no-blame culture, a culture where anyone can raise concerns, and anyone that has looked into this will know that this is pretty standard in terms of team performance. Burke and others also in the British Medical Journal, Quality and Safety, talked about team of experts and expert teams, and again reiterating some of the things. There's a lot known about the design and implementation and evaluation of team training that the medical community can leverage, and critically the aviation industry is one of the ones that is most useful in this regard. Athletics is also extremely useful in this regard. But you've got to have a structured, organised approach to getting your team together, the planning and the preparation, and you must invest. Now, working and achieving this in a university, that's a challenge, because you know that you've got the goal and you know what you've got to do, but getting or convincing people in university to invest in this is a challenge. And actually, Chris Horton said to me very early on in my career, he said, you're going to struggle to do this while you're a junior faculty. And he was absolutely right. It wasn't until I was senior faculty, leaving being head of department, I could actually bully people in the hospital and in the university to give the resources to us to develop this. And of course you have to learn together, task work, teamwork, and so on. So I'm not going to read all of that for you. And there are different phases, team task analysis, simulation exercises, and so on, learning the methodology, how you come up with a strategy to achieve your goals. There's been a lot of chat about learning curves, and so once you've achieved that phase, then we want to know how quickly, well actually the university wants to know how quickly, or any venture capitalists will want to know how quickly they can get a return on their money. So I'd love to have a learning curve like this. This is fantastic. This is, you're climbing up to a high performance level after only a small number of trials, rapid procedural learning, there aren't many I think over a hysterectomy would have fit this curve for me. Heart surgery isn't like this. So I came across this diagram, which is not specifically to do with heart surgery, but it's about skills improvement, knowledge and patient care. It's an ocular surgery article. But some of this rung true for me. And so actually, cardiac surgery is a very long, slow, drawn out learning curve. And it takes a lot of dedication. And if you look at, this is designed to sort of depict people training in surgery. So there's an initial dropout phase. There's some folks that will learn and remain competent, but they've learned what they learned when they were a resident, and they'll do that forever, and that will be a competent surgeon, but perhaps rather brutally put in this zone of mediocrity. But if you want to be, your team want to be successful at this type of endeavor, you've got to keep pushing, even when, and this is a straight line, but it's really a wobbly line. And you've got to keep going through this passion barrier. I'm not sure what passion is, but you've got to be determined enough to go through this. You've got to be resilient enough to go through this phase to get to the point where you and your team are prepared to master your individual domains of expertise, work in a team together to become an expert team. So, what's been written about expert performance? And Erickson, psychologist, was the first person to talk about how an expert performance can be achieved, and he coined the 10,000 hours of deliberate practice. He was talking about expert musicians. So if you wanted to be an expert pianist or violinist or whatever, 10,000 hours. So if you're a normal working day, that's 10 years of anyone's life to become an expert. And that has to be structured. It can be phenotype influenced. So if you've got an entity mindset, you think, I'm naturally good at this and I'm always going to be good at this, and that's it. If you've got an incremental mindset, what you say is, well, I've got some ability, but if I really work on this, I can get to the very top. And that's actually what it means. If you've got phenotypic predisposition and you are prepared to create a structured environment in which you can practice and your team can practice, and you've got a scientific approach, and you're surrounding yourself with reflective practitioners who are united around this individual goal, this specific goal, then you stand a chance to develop an expert team that will perform expertly. And we've heard yesterday and today from several speakers about what a great example there is, and Masami, Chris, Katsu, all, in my mind, are in this area here. They're people who have always questioned, always tried to learn from every case, always trying to improve. And that's what you will need to do. Those of you who know me will know that I'm quite a keen cyclist. And so I couldn't resist mentioning, along with this deliberate practice, the concept of marginal gains, because you'll get to a level, I can see it's raising a smile, which is just what I wanted it to do. Get to a level where actually there aren't big gains to be made anywhere. What you really need to do is, as a team, engage through reflective practice, discussions, engage in a process where you identify even small things that you can make slightly better, and then if you aggregate all of those marginal gains around every part or every domain of what you do, then your overall performance will be better. And this was exemplified by Sir David Brailsford, who was in charge of the British track cycling team, and he espoused the value or virtue of marginal gains, and quite amusingly taunted the French track cycling team when they quizzed him on French television about marginal gains, and he said, it's just, we make sure the wheels on our bikes are really, really round. The irony, of course, was that they were cycling on wheels that were made by the French cycling wheel company Mavic, and so the idea that somehow a French company was selling slightly rounder wheels to an English cycling team was a real kick in the guts for them. So that's all great. So we've got a team, we've got a structured approach, we understand where we're trying to get to, we're working together, coordinating, but then the training comes into it. Now, this is a cautionary note, because what we've heard today is that we want to train other people to do this so that we can make it more readily available. One of the real challenges for anyone that's developed a skill like this in one domain is that, especially when it's a high stakes environment with a low tolerance for mistakes, it's actually really difficult to give the instruments to somebody else. And anyone that's trying to train people to do this is going to experience the anxiety associated with not being in control. It's not that we're control freaks, but that's a very uncomfortable place to be for a while. Volume. We haven't defined what represents a reasonable outcome for mitral valve repair, so it's very hard to calculate what the learning curve is. I'm sure I'm still on it, and I'm sure I've got a long way to go. Once you can achieve this level of performance, what is required to stay at that level? And so if you look in the literature, there's some literature in the veterinary world, a lot of it is in the human surgical literature. So you can see hip replacement surgery, if you want to be good, and if you want to stay good at hip replacements in the human surgery field, 65 cases with at least 15 cases per surgeon per year. That seems quite low. Mitral valve repair in humans, 20 procedures per surgeon per year, but a team that's doing at least 60. Complex thyroid tumor excisions in humans, 30 cases a year. So these numbers seem doable, but NHS England have consolidated all of the heart surgery that happens in England, and Manchester University in particular were looking at their paediatric heart surgery provision, and they determined, having reviewed all the literature, that they didn't want to have any paediatric heart surgeon that was doing less than 125 surgeries per year, and ideally you needed a critical mass of 3 heart surgeons in any single program, and ideally a paediatric heart surgery program would be linked to an adult heart surgery program. So who knows what the actual number that's needed to do in mitral valve repair to stay good, but it's probably somewhere between 30 and 100 on an annual basis. So that's interesting. So between 2015 and 2022, we accumulated 132. So at the start of that period, we were barely doing enough to maintain the skills we developed. And that's a big difference to this, because this, if you look at the little number here, 1,000 patients in a couple of years. So these are worlds apart in terms of acquisition of skills, maintenance of skills, team performance, repetition, and all of that. And I highlight that just simply to point out that that level of repetition, this is an industrial scale mitral valve repair program, which I have the utmost respect for, but maybe that's what you need to do to get those 98% survival to discharge numbers. So what's our routine? Our routine, we've heard this from several folks, but we have multidisciplinary case rounds for case selection, and we evaluate both cardiac and non-cardiac problems. And Mark de Laval, famous pediatric heart surgeon from Great Ormond Street, published many publications on operating room safety and effectiveness. And he commented or demonstrated that comorbidities weren't just additive in terms of risk doing surgery, they were multiplicative. So if you've got one comorbidity, you're in a bit more trouble. If you've got two, you're in trouble squared. So multiplicative. We use pre-surgery assessment. Our patients come in, we get a check on the history, PE, a physical exam, echo, update the team if we need blood work, we get it then. But everything has to be have blood work that's within 3-4 weeks of the surgery day. On the surgery days, roles are important. We work as a team. Very important to have circular communication, the team, and important to do a good handover to ICU stuff we've already heard. And then we always have a debrief following surgery where we discuss aspects of good practice, aspects of or areas for improvement, any unusual events, and again we've heard all of this. More importantly, we come up with an action plan if there is one to be had. So to be successful in open heart surgery and mitral valve repair in particular, you need to be prepared, able and willing to work in a complex socio-technical system that may be different from what you're used to. You've got to be in a team that's prepared to accrue sufficient case experience to become proficient, and you've got to commit to performing a relatively high number of procedures annually to maintain the skills that you develop in the development phase. So if you're going to do all that, there needs to be sufficient reward. And again, this is where academic institutions maybe sometimes fall down, because this kind of endeavour is traditionally not well rewarded in academic circles. We have to do not only clinical work, but we have to do research, we have to be involved heavily in teaching, and we have to have an administrative caseload. So moving a project like this away from academia may be the best, may be the only way to do it really effectively. But there needs to be some local appreciation, team building, and this kind of, my kids always laugh at me when I take a selfie because they say I always look worried. And I am always worried because either I'm going to drop the camera or the phone, or I'm going to push the wrong button and take a screenshot, which is not what I want. So anyway, I was looking less worried in this one. So universities need to be able to acknowledge the effort. There needs to be a pay structure that recognises the effort that's required. I've got profit there because we haven't talked about money, and you have to talk about money. This is expensive. Doing this in a university, we're not trying to make a load of money, but what we need to do is to create enough profit to reward the people that are involved appropriately and to invest in future development and training, because this is an iterative process and it goes on. And sustainability, not just training someone in my own image, what I want to do and what people like me want to do is inspire the next generation to actually take this to the next level. But even more than all of this definition of success is what you see in this picture. This is a dog that had a mitral valve cleft repaired, and actually Masami came to the RBC and looked over my shoulder as I performed this. But this dog was a hunting dog, and it lived a full, normal life. So quality of life for the dog, they live moment by moment, which is nice, I guess. They're not busy planning the summer holidays, so if you can create a situation where they can live a normal life, then that's fantastic. And of course, we see a whole range of different dogs, and whilst we are, as anyone would be, we are devastated if a dog doesn't make it. The dogs that do make it, they go on to lead a normal life and a normal quality of life and lifespan, is why we do this. So I'm just about to wrap up, but I think it's really important to reflect on the fact that this is a complex disease, and when you're treating them surgically or with edge-to-edge repair, there's a huge number of variables. And it reminds me, I'm not particularly mathematically minded, but if you have ever been interested in chaos theory of mathematics, this book is highly recommended. It makes it very achievable to understand for non-mathematical folks. And there's a quote in there, chaos theory hypothesizes that biological systems have a sensitive dependence on the initial conditions, and that small differences and changes can result in a massively different outcome. And that's been my experience with mitral valve repair surgery, is that you can do the same thing, or think you've done the same thing, in 10 different dogs and get almost 10 different outcomes. So I mentioned that comorbidities can be multiplicative rather than simply additive in terms of risk. And really important that we appreciate the massive amount of work that colleagues have done in different centres throughout the world, and that outcomes for an individual centre are not generalisable to anyone that's trying to do this, that they're specific to a centre currently. There will hopefully one day be a day where we can say worldwide, this is what you should expect if you take your dog for mitral valve repair or a TER. But we're not there yet. These are centre-specific outcomes, and it's important for us all to remember that. So you don't have to be Japanese to do mitral valve repair, but it helps. But why does it help? And my experience, my limited experience of watching, observing people in Japan, is that they are uniquely good at everything I've talked about, in a way that Western civilizations and Western cultures don't seem to be to allow. I'm not going to delve any deeper than that. Just wanted to say again a huge thank you. I've thanked Masami, I've thanked Chris. This photograph, this gentleman is Sami Kanemoto, who has a practice in Nagoya. And this photograph was taken in 2010 in a room in this building just downstairs. Augusta Pelosi, the central figure here, gathered us all together to talk about mitral valve or talk about open heart surgery. As you can see, Masami has not aged a second. I have to wear glasses and I've got very white hair now. Jim Buchanan, one of my mentors when I worked at Penn, incredible influence on my life. Interestingly, he never thought open heart surgery would take off. Even more interestingly, he was very skeptical about the role of echocardiography. Strange for a cardiologist. The Japanese team actually have welcomed me, Jasmine, many times. I've always been grateful. A real friend and sort of colleague in private practice in Austria, who's always been incredibly encouraging. Very much credit to him. He's done open heart surgery in his private practice in Austria. This was our team in 2005. We had a perfusionist, human perfusionist. The only person that's left at the RBC in this team now currently involved in heart surgery is Ali, our theatre technician, and she's absolutely brilliant. But I'm glad to say we've got some replacements. There's been lots of people involved. Some people have come and gone, of course, but the current team is, I'll show you in a second. Don't forget the transfusion team. We sometimes make the mistake of introducing the heart surgery patients to the dogs that have donated blood. It usually ends up in another blood donation from the Chihuahuas are never quite so kind to the people that have donated. Here I am, not looking quite so worried about the selfie, but this is Kaylee, Rachel, Matteo, who's sitting in the audience here, is in the team. Ali's just come back to the team. Sadly, Sarah's just left us, but this is the core outwardly facing team at the RBC. This is one of the most hideous gifts we've ever received. This is, I can only say it's a sort of Wallace and Gromit-esque plaster cast of the three of us, Kaylee, Rachel and myself. And I thought I'd just end with a little bit of Halloween humour, British style. Okay, so that's all I have, and I'd like to introduce. I'd like to invite everyone that has presented today to come up to the front, and for those of you that have got questions, please come to the microphone and ask your questions. You guys want to just come and take a seat?